And also I would like to invite Dr. Ravinder. I would like to call upon the stage Dr. Ravinder to chair this session on trauma. Also, I would like to invite our speakers. First would be Mithilesh Raut, and he'll be delivering the talk on whole blood and trauma.
Good afternoon, all. I'm Dr. Mithilesh. I'm consultant intensivist at Medicover Hospital, Madhapur, and I would like to thank organizers for giving me this opportunity to talk. So today we are going to talk on fresh whole blood. Are we reinventing the wheel? Should should I start? So today we are going to talk on fresh whole blood. Are we reinventing the wheel? So invention of the wheel has been a significant step in the history of human mankind, which ushered the prospects of development in multiple walls of the life. So in likewise, transfusion of the blood and blood related products has been an important step in evolution of the medical practice, and which has positively impacted the patient care, and it has helped in getting the better outcomes in the patient. So these two things are major events and can be compared. So necessity is the mother of invention. During the First World War, the fluid dissociation was often done using the saline solution or other colloid solutions. Due to the trauma and the blood loss, during the trauma and the blood loss, they were forced to find other alternatives. So the citrated whole blood was initially included, which is stored in the glass containers. Citrate was anticoagulation; it prevented the blood from clotting, and this helped from the donor to be separated from the patient in time and space. So it could have been shifted from one place to another to fulfill the requirement of any patient who is requiring the transfusion of the fresh whole blood. So in the era of the blood component therapy. So briefly, if we go through the blood component therapy, in 1960, the polyvinyl chloride was introduced in the closed sterile sets, and in which, because of the development, we could make the blood into components. The blood components like RBCs, FFPs could be produced, and they could be stored separately. The components, they had their different shelf life, and that they could be stored for longer period of time. So the components of the blood is 55% of the plasma and 45% of the red cells and 1% of the WBC and the platelets. So this is a very small slide which will tell us about the whole blood. If you centrifuge it, you can get into packed red cells and platelet-rich plasma. If we centrifuge the platelet-rich plasma at 20 degrees Celsius, you'd get platelet and platelet-poor plasma. And the platelet-poor plasma, when it is frozen at minus 20 degrees, you get a fresh frozen plasma. And when we thaw it, we get a cryoprecipitate and factor 8 poor plasma. So basically now we are into the era where we have the blood components which are more in practice. Most of the countries since the 1960s, they are into component therapy. The use of the whole blood has come down. But as we can all know, the whole blood has got some indications in these situations. There are some recent articles which have been published, and they're saying that the old is new. So in next few slides, we'll try to go through the if any indications or any role of fresh whole blood is there or not. So the blood components, when you centrifuge, you get the packed red cells, platelets, FFPs, cryoprecipitate. And if you want to get platelets or stem cell harvesting, you need to do the apheresis. So all these are the advancement in the blood transfusion and blood procurement. So Association for Advancement in Blood and Blood Products International Guidelines in 2023, they've already given that transfusion triggers, and we all know that the transfusion triggers is less than 7 grams in most of the situations. I'll not go into more details of that, but I'll go into the next few slides. So now with the advent of some more sophisticated investigations which are available to us on point of care, like we have thromboelastography. In this, we can actually find out if any coagulation disturbances are there in the patient, in that the specific component of the blood or specific blood product can be transfused to this patient. For example, the patient is having the prolongation of the R time, there is time to start formation of the clot, then the patient may benefit with FFPs. While the patient which is having the prolongation of the K time, the clot reaches a fixed strength, that time he may need fibrinogen. Similarly, the alpha angle, which shows the fibrin accumulation growth, speed of fibrin accumulation, here we give for cryoprecipitate. So overall, over a period of time, we have gone from the whole blood to the component therapy, and there are multiple indications of component therapy, and the same unit of blood which used to be transfused to one patient can be used for multiple patients who need a different kind of parameters, either red cells, FFPs, cryoprecipitate, platelets. So it has been more it has been more economical, and it has been more prudent in the sense where the patients, when the blood and blood products are little scarce, in that situation, the same unit of blood can be used for multiple patients. So overall, it has been a standard practice in the multiple countries, and our country not the exception. So, but we have some situations where we may still need a whole blood, or there have been some interest, or some of the, and mainly this all the data which is coming, or some articles which are coming, they're all from the trauma. So in trauma, as you all know, the patients might have sudden severe blood loss. It might be sudden severe blood loss or massive blood loss, in that we need to replace it. So the conditions where we may have massive blood transfusion may be required is like when the patient is having a severe trauma, a lot of blood loss is there, obstetric hemorrhage, any kind of surgical hemorrhage, bleeding. So in these situations, you can have a massive blood loss, and in that situation, we may have a requirement of this thing. So traditional definition of the massive transfusion may be replacement of one blood in 24 hours, more than 50% of the blood volume in 3 to 4 hours, or almost 150 ml per minute blood loss, or 10 units of RBCs are required in 24 hours. I'll not go through the massive transfusion protocol as it is not the part of this discussion. I just wanted to highlight few important things. And most of the organizations, or most of the hospitals, they have put it as 1:1:1, where you give the plasma, platelets, and RBCs in that ratio, or 1:1:2 in that ratio. So recognizing the limit. So now what we have understood is that the is there any is there any limitation for this thing? So now if the patient has got a trauma in a remote place, or the patient is having a trauma during warfare and multiple wars, they see the transfusion and practice has evolved during the World War I, World War II, during the Vietnam War, and also in during the Afghanistan conflict between the America and the local people. So for the military, it is a different kind, because if you want different components, and if the scale of your trauma, the scale of blood loss, and the transfusion requirement is much more, to store these different kind of blood products which require which have a different requirement for storage at different temperature, it becomes very difficult. So that is one challenge which those people felt. If at all there is a remote civilian trauma center, where it may be very difficult to maintain the platelets, to maintain the FFP, so in that situation also it becomes very difficult. So these constraints are especially important when you consider that the patients suffering from traumatic hemorrhagic shock, time is critical. So to understand, when there is a severe trauma, severe blood loss at that point of time, the time is critical. If at all we delay, or you don't get some components, so for example, if the platelets are not available, if the FFPs are not available in time, so it may cause altered outcomes. So this one the article which I have found in the transfusion journal. So they are working on reintroducing the whole blood for transfusion, and consideration for the blood providers. So this has been done by multiple people. It has been done across the countries, some NHS centers, US centers, and other centers in the different countries like Australia. They have all come to just find out, how to if at all how to modify this situation where all the products may not be available, especially in the remote care. So in the past, only whole blood was allowed in some countries. That too also ABO identical transfusions were given. Now they have moved. So this study, the previous study, the same study I'm quoting, they have found possibility. Can the whole blood be introduced? One. Second thing, what should be the donors? How should we screen the donors? Third thing, how to store the blood. Now, because once you know that once you separate the blood into different components, RBCs, FFPs, and platelets, you have some different kind of storage indications for them. But here, when we see whole blood, the whole blood has been stored as per the RBC survival. So whether the other components are being effective that way, whether the platelets are effective that way, those things also need to be seen in this situation. So they have worked on multiple things, trying to decontaminate, pathogen infection, disinfection, all those things they have worked, and how to go ahead, they have tried to find out some answers. We'll go through it in next few slides. So initially the indication of whole blood was as ABO compatible transfusion initially. As you all know, the whole blood has given way to component therapy, and we also follow component therapy in most of our centers, right? And the latest version of the association of blood and blood product standards, that is also approved the use of low low O whole blood, low titers of whole blood. So they're in this situation, what they try to find out is O blood, O blood group, where they have the less, very minimal or no A and B antibodies. So there are multiple places where they're being used, especially in the air ambulance, the Norway Air Ambulance, the Mayo Clinic. Mayo Clinic also uses covers a very big area. So in that area where there is some remote area where they may not be able to give the blood components in time, or there is not a storage facility, so they keep some kind of whole blood, this whole blood, and which can be transfused in the case of emergency. In USA, the University of Pittsburgh Medical Center, it has been showing low titer cold stored whole blood for several years for all male and female patients. So this is a practice which has been used at multiple places, especially in the emergency spaces or remote places. Remote places which can be your air ambulance, remote places which can be your cruise, remote places where the areas may not be accessible, and other army establishments. So leukocytes and their biological activity factors can impact the red cell and platelets, and thus pre-storage leukocyte reduction of whole blood unit is desirable. So that is one point they have suggested. Plasma and red cell may improve buffering. And additionally, one thing which I found very peculiar is that they said that the red cell, they provide oxygen, they consume nitric oxide and consume activated complement. So it provides, so when you have a whole blood, in that whole blood, what they hypothesized, that RBCs are giving some oxygen and they're consuming complements. So in that situation, it may probably protect the platelets. So this has been suggested by few of the studies. And this appears to be reflected in better recovery and survival of in vivo platelets stored in the cold stored whole blood compared to the cold stored platelets. So now another aspect which they went through and saw in this was any risk of transfusion transmissible infectious disease. So here we have to note that when you give a whole blood that has been derived from one patient rather than different components which are coming from different patients, so the risk of any transmissible transfusion infections in these patients will be less, or it will be as compared or less as compared to the component therapy. That is what they have mentioned. And to limit the risk of TRALI, transfusion associated acute lung injury, the patients, the HLA and platelet neutrophil antibodies, because of the HLA antibodies and neutrophil antibodies, the this association of blood and blood products standards, they have selected a male donor. So they try to limit the, so when this they tried to study, they found that the male patients, one, and the second is the female patients who have never been pregnant, and the women who have been tested negative after their last pregnancy. So these are the patients who they have selectively been taken as a donors in this situation. The selection of the O blood group donors who have very low titer of anti and anti-B antibodies have been advocated as a strategy to mitigate the risk of severe transfusion reactions. So basically they have focused, because see, all we have to understand, when we are in a situation where you have a stable situation, all our transfusion practices, they revolve around the components. That time you can go ahead. But now at this point of time, we are talking about an emergency situation, a situation where we don't have very easily availability of our blood components and blood products. In that situation, we can use O blood group patients blood for this transfusion, and we can tide out the emergency situations. So this pathogen inactivation technology, they have also worked out. They use riboflavin in the UV light, and in that they have increased the shelf life to up to 14 days. So here one important thing also we need to understand is they have cold stored whole blood. Cold stored whole blood. When you collect the blood, it is a fresh whole blood, right? So when I was supposed to talk about the whole blood, the fresh whole blood is one which has been collected at that point of time, right? And for 24 hours it can be maintained with room temperature also. But over a period of time, if you want to preserve it for more time, then you have to store it in colder temperature, almost 4 to 6 degrees you need to store. So in that situation, it becomes a cold stored whole blood. So it is not a fresh whole blood, it becomes a cold stored whole blood. So in that situation, see, first important thing again we need to see is one, It has to be used in emergency situation where the components are not available. And then we need to find out the other components should, if you go only by the shelf life of red blood cells, the other factors may not be optimally active at the time of transfusion. That also one thing we need to find out. And apart from this, we need to prevent any kind of the pathogen or pathogen inactivation processes should be optimal. That one thing also we need to keep in mind. So low titer blood, whole blood. This is IgM antibody titers are less than 250. This one study was done. This study is a pragmatic pre-hospital type whole blood in early resuscitation. So this has been used. Whole blood has been used in early resuscitation in these patients, and they found that the patients were randomized into two groups. One was the one with low titer O whole blood group. This is the one low titer of whole O of whole blood group, and another one the which is less than 24 hours, right? And then they found that no transfusion reaction during the pre-hospital or in the hospital phase of the care documented. So they used this, and they found that there is no additional or more reactions in this group of patients. So this one more. This thing has been published. Here they have explained the concept of walking blood banks. So this is all when the conflicts in Afghanistan and Iraq happened. So the blood component therapy may not always be available. At that point of time, they screened their people, the army officials. They screened, and at that point of time they drew the blood. So that is blood which can be transfused, so that when it is required, those patients can act as a donor. So that is one thing. Since the service personnel, they are already screened for the transfusion risk and they are classified by blood type, they can always be used in emergency cases. This one more study which was published in the Journal of Trauma, where they found out that the patient with a traumatic brain injury and hemorrhagic shock at the same time, they have shown some better benefit of survival with this transfusion of whole blood in emergency situations. So last two slides. So advantages of the whole blood is simple protocol, easy to administer, provides all the components and avoids hemodilution. But we have a shorter shelf life is there because you don't know about the other components, and there are few RCTs. Still, there is not much of the studies which have gone into whole blood because you're all into the era of a component therapy, where component therapy has become a standard of care. And the component therapy, simple protocols, we can use 1:1:1 in the case of the massive bleed. And disadvantage is that it does not replace fibrinogen at all times. So the take home message I would like to tell is the whole blood. Okay, as we have seen in the first slide that we have come across the wheel for such a long time, but all the wheels, even if you want to have some potter, then we need a different kind of wheel. So there is a reinvention of the wheel at this point of time. So you may have a wheel which is alloy wheel for your car, but when you want to do a pottery, you still need the old-fashioned wheel. So we can reinvent it, and we can again use it in the case of emergency. In the cases where, especially when the armed forces or in the remote areas, there is still some possibility where it can be used at this point of time. Thank you.
Thank you, Dr. Mithilesh, for that thought-provoking session on reintroducing whole blood in critical care. Thank you.